Hello and good morning, everyone. I could not join you. Sorry for that. I'm stuck in OT. And my talk is on Botox and pneumoperitoneum, which are the adjuncts in loss of domain. I bring greetings from Gem Hospital. So, whenever you encounter these kind of cases, which on evaluation are found to have loss of domain, you have to use something to downstage these hernias. So, Botox and progressive pneumoperitoneum is one of the commonly used technique to downstage such hernias. Basically, it is not a new procedure. Pneumoperitoneum was done long back in 1940. It decreases the hernia to abdominal capacity volume ratio, also some amount of adhesiolysis, and finally helping facilitate the reduction of hernia. The protocol we use is intraperitoneal placement of a central venous catheter, and initial insufflation is limited to 800 to 1000 cc. This is the catheter which we use, which is 7 French and 15 centimeter long. This is the patient, and we can use an ultrasound probe to identify the correct location. This is the tray which has all the ingredients which we need for creation of pneumoperitoneum. Local is injected at Palmer's point, stab incision is given, the safety mechanism of varus needle is checked, and varus entry is done at the Palmer's point. Once you're sure about the entry, you can do the saline test. So we instill 5 cc of saline and pull out. If it is in the peritoneal cavity, saline won't come out. Take out the hub of this varus needle and insert the guide wire. So once the guide wire is in place, just take out the varus needle and dilate the tract. These dilators comes in the kit of the central venous line catheter. Finally, by Seldinger technique, the central venous catheter is slided inside, and then we insufflate around 200 cc's of ambient air. Now, if you have any doubt, most of the time during installation, you will see the abdomen getting distended. But if you have any doubt, you can use a C-arm to confirm gas under diaphragm. And finally, here you can see the C-arm gas under diaphragm. Finally, it is fixed, and then approximately 800 to 1000 cc of ambient air is instilled. So most of these patients will tolerate that much easily. The hernial strapping is done so that it prevents over distension of the hernia sac. The prophylactic low molecular weight heparin is given, and we do a CT before surgery. Coming to botulinum toxin, which is a neurotoxin, and it acts on the presynaptic cholinergic nerve terminals and causes flaccid paralysis of the muscle by blocking the release of acetylcholine. Coming to techniques, it is usually injected 4 weeks prior, and usually 300 to 500 units according to the body habitus and the size of the hernia. Botox is injected. It can be injected in 3 or 5 point depending on whether you are utilizing the smooth protocol or the Hurtado model. So usually it is injected under ultrasound guidance into all the 3 layers along the anterior axillary line and mid axillary line. So initially, if there is any doubt, one can use a CT and mark the areas where the muscles are thickened and contracted, because the Botox is very costly and the injection has to be in proper site. So you mark out the entry in the CT console, and then finally you can use an ultrasound to inject into all the 3 layers. You can see this the synergistic effect of Botox and pneumoperitoneum, which causes thinning and lengthening of the flank muscles, which finally allows accommodation of loss of domain hernias. So this is the protocol we use whenever we encounter this kind of patients. They get Botox 4 weeks prior to surgery, and this 1 month is the time for optimization of all the comorbidities, and then you admit them 5 days prior to surgery. They undergo PPP for the next 5 days, do a CT scan, see what you have gained, and finally proceed for the abdominal wall reconstruction. Thank you.